Please welcome Nicole Paris to the stage. Ms. Paris is a health program analyst with the Los Angeles County Department of Public Health, Office of Women's Health. She has worked at the intersection of public and mental health for 20 years. Nicole received her PA in psychology and MPH from UCLA. She is also a licensed marriage and family therapist in Los Angeles. Welcome, Nicole.
Thanks so much, Rebecca, and thank you for those great openings. Really glad that you're all joining us today at the second Beyond Silos Domestic Violence and Healthcare Partnership Symposium. Again, as Rebecca mentioned, my name is Nicole Paris, and I'm from the LA Department of Public Health, Office of Women's Health, and I am honored to be moderating this panel on special topics in IPV. We have three wonderful speakers for you this morning to discuss intimate partner violence and healthcare, specifically as it relates to three areas. First, our collective work across sectors, unpacking IPV and maternal mortality. Second, IPV in the context of aging. And third, transforming the public health approach to intimate partner violence. Each of our panelists has been allotted 20 minutes to share their experience and expertise and their current work around these issues. And then we will have roughly 15 to 20 minutes for questions. I'd like to begin by introducing you to our speakers. Sevonna Brown is co-executive director of Black Women's Blueprint. Ms. Brown is recognized as a Miss Foundation Public Voices Fellow for her writing. Her work has been published in Ebony, Time Magazine, For Harriet, and Rewire News. She is a birth worker and reproductive justice advocate. She leads the Safer Childbirth Cities Initiative through the Merck for Mothers program in Brooklyn, New York, and she provides training and technical assistance to a number of organizations through the Institute for Gender and Culture. Second, Dr. Laura Mosqueda is a professor of family violence and geriatrics at the Keck School of Medicine of USC. She is a widely respected authority on elder abuse and care of the elderly and underserved. And third, L.Y. Marlow is the founder and executive director of Saving Promise, a national IPV prevention organization inspired by 5 generations of mothers and daughters in her family that have suffered and survived more than 75 years of domestic violence, including her granddaughter, a little girl named Promise. She is also the principal of the Harvard Learning Lab, an innovative IPV research and development initiative at the Harvard T.H. Chan School of Public Health, and a sought-after advocate, lecturer, and influencer for domestic violence prevention. Again, we sincerely would like to thank you for being here and sharing your expertise with us today. Sevonna, we will go ahead and start with you.
Hi, all. Good morning and good afternoon. I hope that you can hear me just fine and that you all are doing great and having a wonderful day. I'm really excited to enter on the heels of these incredible conversations that are already being led and facilitated. And to share with you all the work that we do at Black Women's Blueprint. So thank you so much to the conveners of this exciting and absolutely necessary conversation for its second annual year in de-siloing our movements and de-siloing our fields. Black Women's Blueprint is an organization which coined the language, the sexual abuse and maternal mortality pipeline. And today what I'm going to be talking with you about are trauma-informed practices for ending maternal mortality. Again, my name is Sevonna Brown. I'm the co-executive director at Black Women's Blueprint and just want to share a little bit of background with you. So next slide about who Black Women's Blueprint is. We are a civil and human rights organization that uses all of those approaches to organize and develop a culture where women of African descent are fully empowered and where gender, race, and other disparities are erased. We are the conveners of the first Black Women's Truth and Reconciliation Commission on sexual violence to have occurred in the United States. Our organization is 12 years old, and we convened the Truth and Reconciliation Commission in 2016. Our focus is broadly, as an organization, our sexual violence prevention, advocacy, training, and technical assistance, research, policy, and technical assistance, as well as healing justice. So I want to share a little bit more with you about this report, the Sexual Abuse to Maternal Mortality Pipeline, which was really designed to outline the concept of the sexual abuse to maternal mortality pipeline as a concrete reality that we see happening within and across the reproductive life course and across the reproductive lifespan. And the report was designed initially to offer an avenue for advocates, key stakeholders, and people, individuals themselves who are accessing maternal and perinatal healthcare to understand their role in prevention and intervention within this pipeline, and to begin really to understand how to develop authentic partnerships. So authentic partnerships like we're building today across domestic violence advocates and prevention advocates and health partners and practitioners, as well as legal stakeholders. And so we really wanted to involve and respect the leadership of those most impacted in the way that we designed the report, the way that we captured the evidence and the materials, as well as did the research. And we hope that what the report does, you can actually access it online through Black Women's Blueprint's website if you are interested in reading it. There are narratives, there are testimonies and stories there. And what it does is it offers an opportunity to gain skills to advocate with and for those who are experiencing sexual violence and sexual violation, intimate partner violence, and domestic violence within their medical processes and also as a part of their lived experience. You can go over to the next slide. So 3 factors really prompted us to develop this, this report and to coin this pipeline. The first was the outcomes of our Truth and Reconciliation Commission on sexual and reproductive violations and the key findings that we found there. There was also existing research on COLEVA, which are the consequences of lifetime exposure to violence and abuse, and ACEs scores that link to what we have witnessed as doulas, as advocates in hospitals, in gynecological exam rooms, in medical institutions. And then also the current state of affairs, right? The political moment regarding the constant threat to reproductive health access, reproductive rights and justice, the closing and shutting down of clinics, and the bans that we see across the nation. You can turn to the next slide. We were also prompted by the data, right? The data surrounding the national crisis in intimate partner violence and the data surrounding the national crisis in maternal health. So we looked specifically at the United States, and we found that there are over 32,000 pregnancies resulting from rape each year in the United States, according to the Bureau of Justice Stats. Furthermore, a research survey that we completed as a part of our TRC, our Truth Commission, found that close to 70%, and we surveyed Black women and girls in particular, experienced sexual violence and some forms of intimate partner violence before their 18th birthday. Local doula services and agencies also showed us that they were inquiring about pregnant women's histories of sexual abuse, domestic violence, and intimate partner violence. And 20% of pregnant people served reported that they had experienced some form across their lifespan. And that actually increased in pregnancy. And people also interacting with OBGYN, physicians, practitioners reported having re-traumatizing experiences. Sometimes those were intentional, and other times they happened as a result of triggers or other experiences that the person had had before, pre-existing PTSD or post-traumatic stress from past intimate partner violence. And then other times there were new incidents of violence that occurred. You can go to the next slide. So this report really examines these markers across the pipeline, and we see those markers as sexual abuse, unaddressed trauma, superimposed social and structural stressors like racism and sexism. We also noticed that there was re-traumatization within medical experiences, which I was just touching on. There's also distrust and avoidance of healthcare professionals. And obstetric violence also was something that we found in all of the evidence in the testimonies. And there was a linkage that was drawn between all of these instances and issues of maternal mortality. You can go to the next slide. We wanted to consider deeply what intimate partner violence prevention advocates needed to know, right? IPV survivors report lasting impact throughout their reproductive lifespan where maternal health is concerned. And the long-term effects of trauma experienced by women in particular is directly proportional to what we found to be the lack of gender responsive care and intervention. And if this is something that you're interested in learning more about and hearing more concrete case studies around, I recommend researching Penny Simpkin. She has an institute that is centered around when survivors give birth, and a book that she also writes that draws attention to the lack of attentiveness or the lack of trauma-informed care for pregnant people and also postpartum women, where issues of domestic violence and sexual violence actually are proven to increase. We found that we lack adequate strategies within the violence prevention movement for how to attend to pregnant people who are dealing with intimate partner violence at the intersection of their pregnancy, and the same for postpartum as well. So you can go to the next slide. Some of the examples that come out of the report, and I hope that each of you will look into it, are that pregnant people do not seek gynecological or prenatal care due to their intimate partner violence experiences. Survivors who report experiences of cultural issues and also instances like virginity testing, which happens across cultures, and other stories of obstetric violence were raised. We also saw non-consensual disrespect and abuse that was demonstrated sometimes at the hands of practitioners who actually may not have gender responsive or cultural competencies. And so we're curious to the physicians and the practitioners who are here in the space with us, what trainings you've also had around intimate partner violence and sexual assault, in terms of how to engage in trauma-informed care, but then also what questions to ask even in a screening with an individual in order to provide exams in a consensual way, or utilize informed consent and body autonomy within your practice. And so just to also unpack a little bit more of those markers, you can see them here along this slide. And we really coined this sexual abuse to maternal mortality pipeline as a result of the 6-year research that we did around gender-based violence intervention, as we were finding that Black women are 4 to 5 times more likely to experience a pregnancy-related death than their white counterparts, and that they were also experiencing preventable maternal deaths. Some of those preventable maternal deaths that are not always archived within even the maternal health index are homicide related, domestic violence related, and a host of other issues that we actually have seen present in documentation and in the research that many physicians have done. We're also seeing issues of unaddressed sexual trauma, which predisposes them to toxic stress and weathering, which is research that has come out over the last couple of years, medical distress and avoidance, obstetric abuse and neglect, and maternal mortality. So I'll just go through these really quickly, these definitions. So if you go to the next slide, you'll see that we articulate that women of color are disproportionately affected by sexual abuse, sex trafficking, fondling, groping, assault, rape, and those resulting in adverse outcomes for their reproductive and maternal health. Sexual abuse survivors, past trauma impacts their full reproductive life course and future. In the next slide, we talk about unaddressed sexual trauma, right? This is the neglect of sexual trauma histories that leads to higher probabilities of re-traumatization and this abuse to maternal mortality pipeline. On the next slide, we deepen this kind of conversation around weathering, which is this complex web of social and cultural relations and anxieties that causes chronic threats to be superimposed. And more research can be found on weathering through Arlene Geronimus, who actually produced some reports that name that people of color disproportionately experience weathering. And you can go to the next slide. And we're talking about Black and Native women who are not just carrying the stressors and toxicity of today, the political moment, but also intergenerational traumas. And all of this also leads to what we talk about on the next slide, which is avoidance and delay of gynecological care, right? there are histories of gynecological care that actually impact people's decision-making about whether or not they're going to access care. Some of that includes unaddressed trauma. Some of that includes societal oppression that's linked to this non-access to care, and that includes gynecological before pregnancy and maternal care. On the next slide, we're looking at abuse within OBGYN care, and this is a really hard topic to talk about, but we have seen more cases rise, especially on the public kind of mainstream stage, where we're seeing dismissive, minimizing pain, and even sometimes obstetric violence occurs. On the slide, we articulate that these are, trauma symptoms re-triggered, right? This is showing back up for individuals when some of the behaviors that they experience within the medical field actually reflect what they're experiencing at home or past experiences. Obstetric violence, which is next, is this kind of normalizing of mistreatment and disrespect and abuse, which we now have a definition from WHO, after many women have shared their stories of what they've experienced inside of maternal care wards. And then finally, maternal mortality and morbidity, which is the pattern that links unaddressed trauma, intimate partner violence, and issues of maternal mortality and morbidity, ultimately showing that there's a link and causation between what people are experiencing in their personal lives, and that impacts their health. And so in the last 2 minutes, I would really love to show you this final slide, which is about what advocates might be missing, right? When we define sexual assault, when we define violence, when we define intimate partner violence, and we define domestic violence, there are various forms of violence that are occurring across the lifespan. And so within the 3,000 surveys that we were able to collect from our Truth and Reconciliation Commission, we find that this is what people are experiencing across, if you were to define it within a full reproductive life spectrum, and the violations that occur, right, from prepubescent, as early as 7 years old, to adolescence, to childbearing years, to pregnancy, labor and delivery. And there's certainly an expansion of this timeline, this lifeline, and this life course that needs to be defined that goes into the postpartum period, which is a very sensitive and vulnerable time, and toward even through menopause, right? And so one thing that I hope that you all will take away is that regardless of whether or not a person is childbearing, there is a reproductive life frame in which, and a life course in which our lens must be trauma informed, right? We must take into account and into consideration across all of these areas of an individual's life where they may be existing inside of violence and seeking help and support, right, from community. So grateful for the time that we had, and I know that it was short and fast. But if you want to explore this report further, you can find it on blackwomen'sblueprint.org. You can read the report, you can sit with it, you can look at the recommendations that we make around policy, medical practice, and also culture shift. So thank you to the audience and for the conveners for the time that we've had. I'm so excited about the next set of presentations, which I know will be powerful and build on this conversation. So I'll turn it back over to the team.
Thank you so much for that important presentation, Sevonna. And now, Dr. Mosqueda, if you are ready to go, your 20 minutes. Thank you.
Great, thanks. All right. Well, it's great to see everybody. Just to get it out of the way, yes, I do get called Dr. Mosquito a lot. So, but my name is Laura Mosqueda, and I'm a family physician and a geriatrician at the Keck School of Medicine of USC. And I'm really delighted to be asked to talk about IPV in the context of aging. And I'm especially delighted to be sharing a panel with Sevonna Brown and L.Y. Marlow, who have remarkable bios, and I know we're going to learn a lot. Already have started. So thanks for the invitation and letting me join you to talk a little bit about the aging issues. So let's talk a little bit about IPV in the context of aging. And sometimes we talk about it kind of living in the margins, because there's a whole field of work in the area of elder abuse, and then there's all this work in IPV. And even though we know it's like a Venn diagram where there's a lot of overlap, we don't talk about it that much. And there's sort of a sense of, well, they're taking care of it. No, they're taking care of it. And that sort of leaves older adults who are survivors a bit invisible. And in fact, IPV research does focus on women of childbearing age. If you start looking at issues of IPV and research in IPV for older adults, I hate to break it to you, but older adults starts at about the age of 46. Now, in my world as a geriatrician, 46-year-olds are still kind of, that's still pediatrics for me. But in the world of IPV, this is where people really start to talk about aging. I'm going to be talking about truly older adults in their 70s, 80s, and beyond, because I think that's an area that doesn't get discussed enough. And in fact, the U.S. Preventive Services Task Force says we should screen women up until the age of 45 for IPV, which means that 40% of women are kind of, again, invisible, not being screened. If you think about symptoms of IPV, they include things like sleep disturbance, digestive problems, difficulty with concentration, feelings of hopelessness, worthlessness, depression, chronic pain. If I were then to just say, let's not call it symptoms of IPV, keep the same list and call it symptoms of aging, hey, a lot of people would say, this is what happens with aging as well. So what we find is that the normal and common age-related changes can mask and mimic signs of IPV, which means we all have to be especially alert to issues related to IPV in older adults. And I thought maybe an interesting way to do this with all of you today was to go through 3 cases. Each case, each person in the case will exemplify a really different aspect of what happens with IPV and aging. And at the end of my talk, I'm going to throw down the gauntlet and ask people to really think about what we all can do differently and better for older adults who may be victims of IPV. All right, so I'll go through this first case, Mrs. C, based on a real patient in my practice. She's an 86-year-old woman who came to my office for just a general checkup. And she had recently moved to the area from the Midwest. She wanted to establish care with a new primary care doc, generally healthy, was being well treated for high blood pressure, depression, and arthritis. And she'd been in a very good marriage for 55 years through 3 adult children, all doing well. And I let her know, I just normalized the questions. I ask all of my patients about any past events that may have been really difficult or particularly traumatic. And I asked that question and she started crying. And she said she had a first marriage that was filled with abuse that she had kept hidden from everybody. She had never talked about it before. And this was the first time anybody had really directly asked her about it. So this is an example of somebody who, you know, seems like they lived a really good life, and in fact, she feels like she has lived a good life, but the impact of her IPV early in life had never really fully been understood. And we see this, that women who were physically or sexually assaulted decades before still have symptoms of PTSD. They may start to get expressed differently as we age. But one of the really special circumstances that we see with older adults is, let's say this woman goes on to develop Alzheimer's disease or some other sort of dementia, where you tend to have old memories still present and have trouble making new memories. What kinds of re-traumatization or memories might start coming up for her that we won't even understand? What if at some point she moves into a nursing home in order to get appropriate care? And what will it feel like if now people are, you know, helping her appropriately, but they're doing work in very intimate aspects of her life with bathing and grooming and hygiene and all that? Will this now bring up some of the memories that she had earlier in life? So this is an example of what happens early in life with IPV as you live into old age. I'm going to go talk about our second person, and that's Mr. A. Now, he's a 71-year-old man who has Parkinson's disease, and it's pretty advanced Parkinson's disease. The illness started about 7 years ago. He received all the appropriate treatment, you know, physical therapy, medications, something called deep brain stimulation. But now it's really moved along. He's had frequent falls, was in the emergency room multiple times. It's pretty common for people with Parkinson's disease to fall. But in fact, he was in the emergency room 6 times in the past 5 months last year, and now he's needing more and more help. His caregiver is his wife, and she has to help him with all kinds of things. He can't get out of bed into his wheelchair without her help. He wears a diaper. He needs someone to help feed him, and they've been married 45 years, and she's now coping with all of this. He hasn't been to a doctor in about 8 months, and she calls 911 for him to go to the emergency room, and she tells the folks in the emergency room, look, he's not eating, and I can't take this anymore. So when they look at him in the emergency room, he's emaciated, he's incoherent, he has multiple deep infected pressure sores on his back, his buttocks, and even on the back of his head. And a social worker gets involved and interviews the wife, and the wife says, look, he was never a kind man. He always controlled the finances very tightly. He yelled at her. He yelled at their children. Every now and again, on a rare occasion, he would actually hit her, but she never sought medical attention. She never viewed herself as a victim of IPV. She never told anyone about it. And now that he's requiring more and more care, she feels like it's kind of his turn to see what it's like to be on the other side of things. And this is where you have a couple where one has, or maybe both of them, have been involved in some form of violence against each other. And now there's some aging and the power dynamics begin to shift. One person becomes more frail or disabled or develops a dementia. And now the person who was more of the victim may become the abuser. And so we have to recognize our own feelings about this, because obviously she was a real victim of IPV, but we have to be careful to say it doesn't mean it's okay to now abuse your husband, who was becoming neglected almost to death at that point. So this is another type of IPV we see in aging.
Dr. Mosqueda, sorry to interrupt. I know you're flowing here. Just curious if you wanted to continually advance the slides. They're not advancing on our end.
They're not advancing?
No.
Wow, that's a interesting problem. What I might do is I'll keep going. I apologize. I had no idea I've been advancing slides and thought I was advancing them with the audience, but hopefully you guys can put up with it. We all know what the craziness is with technology these days. So I'm going to keep going, and the folks behind the scenes can interrupt me if they do end up being able to get my slides on and advance them for me, because it'll frankly be most important for the end. So just a quick recap. We've talked about one story, Mrs. C, the 86-year-old woman who had had early IPV and then a very successful marriage, but now it was beginning to catch up with her. We just talked about our story of Mr. A, the man with Parkinson's disease who had been an abuser and now was getting abused by his caregiver wife. And now I'm going to tell you the story of Mrs. D. She's a 67-year-old woman whose husband died a year ago. They had a very good marriage. They were high school sweethearts and had been married since the age of 19. It was a great marriage, 2 adult children, both of whom live across the country, but close relationships. And since the death of her husband, she's really felt sad and lonely. And a 42-year-old handyman comes into her life to help fix things around the house. And they started getting to know each other. He started helping with grocery shopping, other sorts of errands. And her children and her friends are shocked to learn that last week they got married. And now that they're married, he's isolating her from friends and family. He has taken control of the finances. He's the husband and has gotten legal authority to some extent. He invites his friends over on a regular basis for parties. And when she starts objecting to his behavior, he threatens her verbally and physically. One night, he's quite drunk. He hits her. She sneaks out of the house to the emergency room, and the providers there talk with her, realize it's an IPV situation. And then with her permission, cooperation, direction, they create a safety plan. They call her family to help them get re-engaged appropriately. and a few weeks later, she moves into a shelter. So this is really new onset IPV. So this is a third type of IPV we see with older adults, where somebody may become lonely or more vulnerable after the loss of a spouse or some other sort of incident. And it's very similar dynamics that we see with younger people who have IPV, right? A cycle of violence, then a progression of violence, and the use of power to get control in a variety of ways. So those are three real life examples of IPV in old age that show sort of the depth and breadth that can occur. I'm going now to talk about barriers to progress, and we'll pause to see if we have any luck in having my friends behind the scenes with slide control here. So there are internal barriers, like people feeling that's my fault, all the stuff you guys are really familiar with. The idea of secrecy, we have to keep it within the family, or embarrassment, not knowing where to go to talk about this, lack of knowledge or trust in services, financial dependency on the perpetrator, and ageism. And you'll hear me talk about ageism all the time in terms of barriers, because we're ageist about ourselves too, which is, well, I'm getting old and this is what happens when I get old. So ageism is a pervasive problem that we see in elder abuse and intimate partner violence a lot. There are also external barriers. You might be in an unsupportive community. We might have problems with the way law enforcement and the courts are responding with older adults. There's lack of knowledge about aging in older adults. So is the person demented? Can we believe what they're saying because they have Alzheimer's disease? And so older adults end up having sometimes triple whammies. You know, they've been victimized, they're aging, they may have a dementia, and nobody believes anything they say, and everything gets attributed to, well, they're just old, or gee, they're on a blood thinner, so of course they bruise easily. So this also gets us back to ageism kinds of issues as well. Ageism is a strange ism. You know, when you think about all the different kinds of isms we have, this is the one that's a prejudice against our future selves. So we really ought to think about this one a little more carefully. There's lots of barriers to effective intervention. As the title of this whole program suggests, there's silos. And so we don't have good cross-system collaboration and reporting, and we frankly don't have enough age-appropriate services. So when we send an 80-year-old woman to a shelter, and there's a lot of kids running around, and people aren't knowledgeable with how to help necessarily with issues like getting in and out of bed and administering medications and memory loss and hearing loss, we don't necessarily have age-friendly shelters. So there's lots of different things we can do, and eventually when you see my slides, you'll see a long list of what can we do on it. And so what I would say is, first we got to recognize that it happens and ask people about it. We've got to work more at partnerships. We have to adapt what we do have for older adults so that it really works for everybody. And we have to work at interagency collaborations much more strongly. You know, what we want is for older adults, I'm assuming right now that people still are unable to see slides advancing. Is that correct?
Correct. Sorry about that, Doctor.
Okay, so I think maybe the best thing to do is to end it here. I had a really cool slide to end on, and you'll just have to hold your breaths and wait and see it in your own good time. But of course, what we really want for all of our older adults who are aging, related to IPV or not, is that they're treated in a dignified and humane way. It's just as important when you're 95 as when you're 35 to have meaning and comfort and identity and joy and inclusion in your lives. It's important that we treat everybody with dignity, respect, and I think love. And so on that note, I'll end. You'll see on the very last slide when you get my presentation that there are a variety of resources for you to access. And I just want to thank you all for your time and attention. I'll stop screen sharing now, unless it's already off. And hand the virtual mic back over.
Yes, thank you so much for that presentation, Dr. Mosqueda, and for your patience. I know the tech issues can be distracting. So, but we really do appreciate your time, your expertise, and the great case examples to really highlight IPV in the multiple forms for across the lifespan, right? And how those early impacts and traumas can carry on, and then also the opportunities, unfortunately, for relationship abuse as we age. So again, thank you very much. We are going to move on to L.Y. Marlow for her presentation, and then we will be bringing everyone back up for a little Q&A session. So L.Y., are you ready? So as we wait for L.Y. to come on and her slides to appear, just do a sound check. Again, I want to give a lot of thanks to those two presentations we've had so far. Hopefully they're making all of us think about just those connections, right? As the supervisor and Blue Shield and Genesee have all kind of prepped us for, there are so many different connections. There are so many intersections, and that when we're addressing issues of violence like IPV, we can't ignore or de-silo ourselves. And so this collaboration is even more essential. And when we throw the trauma and the impacts of trauma and unresolved trauma on health, we have a lot that we're all dealing with. And I think as providers, most of you probably see this, but as agencies and systems, we're not set up to deal with it. So again, even more reason for being here today and having these conversations. I do also want to say that because we are discussing some really, difficult topics, that just to take a moment for yourself, kind of check in, see how you're doing. As we know, because these issues of violence and abuse are so prevalent, trauma is so prevalent, chances are we've all experienced something in our lives, if not directly, but with someone very close to us. So just take a moment, check in, take a couple of deep breaths, stretch, get a cup of tea or some water if you need to. But again, later today, we're really going to talk about, self-care and dealing with listening and being witness to people's, tough stories and their journeys to healing. So just as kind of a little precursor to that, take a moment for yourselves now. I will go ahead and maybe start some Q&A for Sevonna and Dr. Mosqueda until we can get L.Y. Connected. So if it's possible to, perfect, there you are. So one of the questions, since you both have tremendous experience in your fields and with your specific populations, what's one of the kind of persisting myths or misconceptions about IPV when it comes to your specific population that you feel like people keep repeating that myth or they keep having that misconception?
I mean, I can talk about several of them, especially when it comes to communities of color. And I think, one is that there's often an idea that it's purely relational, right? But it actually takes the form of communal, societal, structural, systemic. And so we all really have a role to play in dismantling violence and interrupting and preventing violence. And all systems, have a role to play in raising awareness around it and addressing it. And so I'm incredibly grateful that we're talking about de-siloing. And I think these two kind of fields and sectors coming together can actually demonstrate how other fields and sectors can come together, right? Because this issue of intimate partner violence is not just relational or individual or happening in dyads and triads. But really, people are surrounded by communities where this can either be perpetuated or it could be interrupted, right? Or they're inside of systems where it could be caught It could be prevented, it could be addressed directly. And so I really hope that we can be moving towards a way and towards an understanding and expansiveness within our fields to say, oh, that doesn't just happen to certain kinds of people or in certain types of conditions, under certain kinds of conditions. But there's a broader, I think, bird's eye view that we can take that allow us to actually lock arms together across our sectors and come up with a full big picture scope of work and strategic plan for how we end intimate partner violence.
Great point, Sevonna. Thank you so much for that. And Dr. Mosqueda?
Yeah, I think these contextual issues are incredibly important. And I think when it comes to IPV and aging, there's just this tension between the two fields that sometimes we don't want to acknowledge, but they're there. I mean, they're there. And so who owns it and where does the funding go? And so we end up in, frankly, unproductive tussles that don't help the people we're here to serve. And I think we have to be honest about it, acknowledge it, and see how we're going to work together so that we're not constantly competing for funding, but recognizing we're all people. And there's nothing magic about when you cross a particular age. We're working right now with the NIA, the National Institute on Aging, which is part of the NIH, to say we got to fund more research in the area of elder abuse that includes issues related to IPV. And sometimes I think we get so cut. Part of the silo issue is, there have to be definitions so that people know about funding streams and people know about labels and all that. But the labels don't necessarily serve the people who are suffering very well. They just want to live a good life and get help. And so I think in the professional realm, we have to kind of get past ourselves on this.
And I think what you're naming, if I could just build on that, Nicole, is you're naming that people live at intersections, right? So to categorize or marginalize someone within an identity actually doesn't serve the philanthropic world's efforts around like how we resource issues like this, especially when people have intersectional lives, conditions, and identities. And if only we could bridge those definitions without creating more limiting terminology, right? But finding ways to think, I think, with greater depth around the issue at hand.
Perfectly said, yeah.
Yeah, such great points. And Sevonna, that was actually, as Dr. Mosqueda was speaking, that was something I was thinking about too, was dismissing the violence was kind of our first pitfall, right? Or not believing the violence, and then kind of dismissing if somebody doesn't fall neatly into a category, right? And so saying, well, that's their realm or that's their service that they provide, and really not looking at the whole picture, the whole being, and the population. So really appreciate those comments. So kind of looking at how the field has changed over the years in your, experience, what has been one of the most significant changes in how the domestic violence in the healthcare systems either view, treat, or incorporate intimate partner violence into their work, specifically with, populations as they age or within the maternal population? What have you seen as one of those significant changes that is really kind of bringing people out of their silos?
I would offer that a significant change that we've seen is the rise actually in centrality of survivor leadership, right? There's been this destigmatizing and this demystifying that survivors and individuals who are most impacted by violence don't have the answers for or have the solutions, right? Like we now actually have an understanding that there's a role and a seat at the table for survivors to inform policy, to inform practice, to inform services, to lead and develop organizations, right? And it's not that that wasn't happening before, but there was a stigma around victim versus survivor, right? Around the emotional availability and capacity and strength and resources of an individual who's been impacted by violence to actually lead the charge. And I don't mean that just in a political way or an advocacy way or even an activist way, but just I think across the field, we've seen a lot more leadership voice of survivors informing agendas and setting stages and writing and enlisting around reports and also leading trainings, right, around what trauma-informed practices need to look like inside of various sectors. And I just believe that that was not necessarily where we were coming from in the beginning, even though survivors have always been leading, right, have always been at the forefront. So I think we've evolved a lot, and there's been significant changes that are not just for the current moment, but will also have intergenerational impact and define and set the course for how it is that we get to do our work going forward.
Great points. Great points. Thank you.
Yeah, and I would just piggyback on and say, you know, in the field of aging, we hardly talk about this. You know, geriatrics, you do it to your fellowship, whatever. We don't really talk about family violence in it. And again, maybe because I'm a family physician, I sort of have this life course perspective. There's nothing, again, magic that happens overnight with aging. It's all a gradual process. And the point that Sevonna made earlier, like just, it's all transitions. Everything is constantly a transition. We're always living in between. We just have this, it makes it easier to say we are here right now, but we're always in between, and have to consider it that way. I think we have to ask and listen and believe. And very often older adults do not feel empowered in any ways. If you go to a bookstore and look at the section on aging, you'll find a lot more books on anti-aging or how not to age than on how to age well. As far as I know, there's still only one way to not age. So nobody wants that one. So, you know, the ageism that's so pervasive in our society does become double, sometimes triple jeopardy for people. And the last thing I'll mention again is for older adults who have a lot of physical frailty and or cognitive impairment, which often coexist, it's hard for them to be empowered to speak up for themselves. But I still believe that at least some can, and we need to really make sure that we're hearing their voices as well, and the voices of those who love them.
Great point. Thank you, Dr. Mosqueda. And that actually leads me to one other question. You know, we've talked about kind of this journey, right, from experiencing the violence and abuse, recognizing the trauma, and then healing. And are there any specific either healing practices or services that you've seen be, you know, just really kind of beneficial for some of your population? I mean, obviously people heal in different ways and at different stages, but, you know, anything in particular that's been really helpful?
Well, I mean, at Black Women's Blueprint, we use cultural approaches and even non-traditional methodologies bridged with, you know, psychosocial approaches. And it's always survivor-led and survivor-defined, right? And so for some, it might mean bringing in aspects of their culture or healing rituals and modalities that are within the tradition of their family and their community, and matching that, right, with mental health, professional guidance and advice and support. But everything, especially when we talk about this intersection of violence and health, is and should be steeped in a somatic approach, right? Connecting the brain and the body, right? So for some people that looks like dance and movement. For other people, it looks like breath work or something they can do sitting down. But it's also a journey, right? At different moments across one's healing journey, a different methodology and modality might be needed, right? But I think the best thing is that it's initiated and determined by the individual who's been most impacted, and it bridges the brain and body connection, which we've seen now more in the field is necessary.
Definitely. Thank you so much. Okay, so apologies for interrupting. It looks like we have LY on. Can you hear me okay, LY?
I can hear you now.
Oh, perfectly. We can hear you as well.
Okay, good. Oh my goodness. Well, you know what? Welcome to virtual reality. Okay.
Great. So go ahead and take it away, LY.
All right. Well, the best place to start with this is that Arthur Ambrose once said, fear is not the absence of fear, but rather the judgment that something else is more important than fear. Who knew that I would someday have to confront my something else and find my courage, a courage that would ultimately change my life? I remember it so vividly. And just let me make sure I'm sharing my screen here. Are you seeing my screen?
Oh, now it's popping up.
Okay, you see my screen?
There you go. Sure.
Okay, good. Thank you. I remember it so vividly. The year was 2000, August the 25th, 2007. The phone rang and I heard my daughter's voice on the other end. I hardly remember the drive from Washington, D.C. to Philadelphia. I just remember sitting there and listening to my daughter tell me how he beaten and strangled her, and how she was, as she was blacking out, she heard their 6-month-old baby girl named Promise screaming, who lay on the bed beside her. I closed my eyes and my heart broke, and I thought, no, not again, not Promise. You see, this was not the beginning. I had spent years writing my book, Color Me Butterfly. I had talked about how I had to relive the story of my grandmother, my mother, myself, and my daughter, about how my grandmother had to withstand vicious abuse from my grandfather as he abused her and her 8 children, and how he even once forced their 3-year-old son to eat a dead rat. About how the time my mother lay in a hospital bed with stitches from the top of her neck down to her navel, and now told to kiss her 5 babies goodbye because my father had beaten her so badly, he burst both her lungs. And the day my boyfriend kicked me in my 8-month pregnant belly and spit on me. The first time my daughter was almost killed. And now here was Promise, the 5th generation. That is the story that inspired me to walk away from a national corporate career to launch Saving Promise, a domestic violence organization that's focused on greater public education and prevention. You know, we've all seen and heard the all too familiar stories, the data, the stories of 1 in 3 women and 1 in 4 men who have experienced rape and physical violence or stalking, and many for the first time before the age of 25. That 1 in 4 children have witnessed violence in the past year of growing up in a home with domestic violence. That 72% of murder-suicide involves intimate partner violence. You know, I was at a conference that I hosted back in 2015, and I partnered with Johnson & Johnson, and we had invited subject matter experts from every sector of the community, from academia, from corporate, from public health, NGOs, to see how we could work collaboratively to prevent intimate partner violence. And I remember Dr. Jim Mercy, the then and still now the director of violence prevention at the CDC, he put up this slide that you're seeing, and he said, what if there was a world where there was a disease that can trigger cancer and heart disease and HIV/AIDS and mental health issues and PTSD and other communicable and non-communicable diseases? And I remember not only I, but everyone in that room sat there and we were thinking, oh my God, what disease could that possibly be? And then he brought up this slide and he said, there is such a disease. It's called intimate partner violence. I will tell you that that was the first time, even after coming from 5 generations, that was the first time that I had a moment of stillness, a moment of clarity that I had never had before. Intimate partner violence is a public health crisis of mass proportion, And the trauma that it causes to not only victims, but perpetrators and families and communities. The trauma that it causes. For example, the trauma is a ripple effect. There's the physical trauma and the emotional trauma and the mental trauma and the PTSD like anxiety, depression, and substance abuse, traumatic brain injury, relational trauma. There's maternal mortality. We heard about that a little while ago, the maternal mortality that it causes, and then early childhood trauma. This thing is real. This thing, and I call it this thing because it is a public health crisis. This thing is so real. You know, one of the things that is really more prevalent that we're learning just in this last decade, though we know it's been there for ages and generations, is the mental health impact. For example, intimate partner violence survivors experience 54 to 84% experience PTSD. 63 to 77% experience depression. 38 to 75% experience anxiety. And 60% abuse substance, obviously to cope. And then when you look at the impact on children and the adverse childhood experiences that IPV impacts, you know, children who witness abuse carries the same risk of harm to children's mental health as being abused directly. Witnessing it is almost like being abused directly. There's a greater risk of emotional and behavioral and physical problems, including depression, anxiety, unhealthy behaviors, and suicidal thoughts. Children who also witnesses intimate partner violence are likely to have PTSD as much as soldiers returning from war. Think about that. They may experience PTSD at the same impact and traumatic experience as soldiers returning from war. Brain imaging in infants shows that exposure to domestic violence, even while sleeping in the uterus, can reduce parts of the brain. It can change its overall structure and affect the way circuits work together. Higher likelihood of witnessing intimate partner violence as a child also can trigger them to become a perpetrator or victim later in life. And then babies who were born to mothers subjected to violence have 3 times the level of inflammation in their bodies than an adult. We heard Sevonna sharing the news about this. Our children are at grave risk. And when you look at the risk factors across the community, the health and the economy, and look where the health is, it's dead center in the middle of it. So on the community side, there's increased levels of severe violence across the lifespan. There's anticipated increases between the intersections when you think about other things that intersect with intimate partner violence, from mental health to suicide, to homicide, to poverty, to drug and alcohol, to homelessness. It's pervasive. It increases the injuries and mental health and non-communicable and communicable diseases. And we got to think about the astronomical increases of healthcare costs. And speaking of healthcare costs, when you look at the economics of it, there's an anticipated increase in annual costs of intimate partner violence and related injury and intersections that is estimated in the trillions globally. And not to mention the increased costs in social services, law enforcement, and other intersections, including healthcare providers that are treating or responding to trauma-related issues. And guess what? Guess who's paying for it? Guess who's paying for it? You. You know, that reminds me of, some time back when Oprah was giving away those cars on her shows, and she said, you get a car and you get a car. Everyone gets a car. Well, guess what? You get the burden. You get the burden. Every one of us here today, carry that burden. This is the time to start talking about breaking down the silos. Now is the time, because intimate partner violence is a public health volcano ready to erupt. We recently at Saving Promise, along with our partners, wanted to just over the last few weeks, wanted to conduct a national public opinion poll to identify and explore the mental, physical, and emotional effects the pandemic has had as it relates to the potential of exacerbating domestic violence. This data just came back to us last week. So this is real current data. Here's what we found. 45 to 65% people share that their relationships have suffered as a result of COVID. And we all know why. Quarantining and everything that triggered so many challenges for us. 58% reported worsening of their significant other's temper. And it was slightly higher for those with children. More than 52% agree that their state of mind and their mental health has gotten worse over the last 18 months. And 1 in 4, as a result of all of that, if you think about all the things I just shared, 1 in 4 personally have experienced, and these are people that may have also never experienced it in the past. I know we have the common number of 1 in 3, 1 in 4. But we're talking about new folk who is now starting to come forward that said in the last 18 months, previous victims and non-victims and perpetrators personally experienced it in the last 18 months, and very much so in the realm of emotional and verbal abuse. When we asked about, do you personally know someone in the last 18 months that experienced it? The Generation Z and the millennial generation were very high on the charts. 50% of Generation Z and 43% of millennials said absolutely. And not only did they say absolutely, they know someone, but many of them themselves were victims or perpetrators. And then 76% said they wish they would have handled their own situation differently. They wish they would have handled their own situation differently. And 79% said they wish they would have done more to help someone they know. 67%, get this, 67% said they would feel more comfortable talking to someone about it. People want and need help. People want and need help. And of those people, 43% said they undoubtedly want to talk to their healthcare providers, their physician, their nurse, their therapist, health administrators. They want to talk to their healthcare providers. And of that, 1 in 4 Generation Z said that they would prefer to talk to a healthcare provider more than law enforcement. Let me say this, and if you don't hear anything else I say today, this conference is not about whether or not should we bridge the gap. This conference should not be about whether or not we should have conversations about when to bridge the gap. This conversation has to be about breaking down the silos. We need the healthcare sector to be on the front lines with us in this, because this is real. This is real. It is so real that when I think about the 5 generations in my family, when I think about my grandmother and the physical, mental, and emotional acute trauma that she suffered, when I think about my mother and the physical, mental, and emotional and acute trauma that she suffered, when I think about my own suffering, severe physical and emotional trauma, and maternal health. We heard Sedona talk about the maternal health, particularly on Black women. When I think about my daughter who suffered from strangulation, head injuries, from severe trauma and maternal trauma as she was pregnant and carrying Promise. And then when I think about Promise, who born into that, both pre-trauma and post mental, emotional, and physical trauma. And I'm not ashamed to say, even to this day, Promise sees a counselor, a therapist, because of the trauma. And then when I think about that trauma on that chart that Jim showed us many moons ago in 2015 is real, because this is how it affected one family. And not only did it affect our family in terms of the trauma, but my mother would later pass away 40 years later from lung cancer due to the trauma that my father had inflicted on her nearly 40 years ago. So the generational trauma is carried in the body. I think of that book that calls The Body Keeps Score. The body keeps score. My mother died 10 years ago, nearly 40 years later, from the trauma my father inflicted on her lungs. And to this day, in the last several years, have been diagnosed with PTSD and life-threatening health issues. And guess what? Someone talked earlier about the impact that is having to advocates. Well, I am one of those. I was diagnosed with life-threatening health issues that attacked every part of my body, my brain, my heart, and my autoimmune system, due to the chronic stress of trying to save Promise. And when I say trying to save Promise, I'm talking about the promise for us all, the promise for our families and our communities and our children. This is real. And the healthcare providers, you all have a unique and critical role to play. If you think about it today, do it. If not for my family of 5 generations, my grandmother, my mother, myself, my daughter, and Promise. If not, do it for the countless men, women, and children that are affected by this public health crisis. Do it for the community advocates and stakeholders that show up every day on the front lines. Do it for the men and women in law enforcement that put their lives on the line every day. Do it for your peers and your colleagues, because you are the ones that we turn to behind those closed doors. Or do it for your family and your friends and your community. We got to do it, because what's needed now is that healthcare providers can be engaged in an informed response in the screening, in the intervention, in the safety planning, in the reporting. Healthcare providers, you all can offer support and build trust. We already trust you. There are two people that we trust more than anything in our lives, every one of us. When somebody touch our hair, we talk to our salon stylist or barbershop, we tell them everything. And when you close that door or you close that office window, you have our trust to open up. So you already have the trust. And then you can validate that trust and help us share resources. You can help us improve health outcomes. We can't do this alone anymore. And ultimately, you can do what you do every single day. Every single day, you save lives. So what's needed? A disruption. Public health agencies would typically place prevention at the forefront of efforts and work to create broad population level impact, can bring critical leadership. We need your leadership and your resources to bear on this problem. It is no longer, folk, a conversation of if or when. It is a conversation of now. It is a conversation of now. We are beyond silos. We are beyond silos. We cannot operate in silos any longer. We cannot operate in silos any longer. We have to come together. This is a public health crisis of mass proportion. The United Nations women tagged it as a second pandemic. A second pandemic. We have the ability, when we look at the intersections of domestic violence and health equity, we can have a systematic response, not only to achieve health equities, but also domestic violence prevention. We can reshape outcomes around wellness and mental health and economic and safety. We can foster multi-sector collaborations and bring collaborative partners from every sector. And ultimately, we can shift norms. We can reframe domestic violence as a public health issue to change behavioral attitudes and norms to decrease the tolerance and ensure that we have a systematic response when we talk about health equity. And that is why, as I close, I want to talk a minute about a new initiative. There are many initiatives you're going to hear about today. This is where it's going to be very critical for us to come together and figure out what's working, what's not working, and how can we scale those things that are working. One of which is between us in collaboration with our partner at Harvard T.H. Chan School of Public Health. We have a new initiative called Between Us. It was actually something I came up with 8+ years ago when I learned that my daughter was almost killed for the second time, and I was the last to find out. And I thought to myself, wait a minute, she has the workplace. She has a job. Why didn't she turn to her employee assistance program? She was in school at the time. She could have went to the school campus health center. She was seeing a doctor. Why didn't she turn to her healthcare provider? She was a member of a church. Why didn't she turn to her faith leaders? This is an opportunity where we can have an initiative called Between Us. What better way to talk about it than someone you can trust? After all, it's just between us. A comprehensive and integrated public health initiative to promote safe and healthy relationships to prevent intimate partner violence. And in fact, the whole notion is we want to bring community-based partnerships together from the grassroots, and as you can see to the right of this slide, the healthcare sector, to make Between Us and other initiatives that are working available in hospitals and doctors' offices and farmers and community health centers and urgent care. You know, and looking at how do we look at this as a comprehensive model to really bridge the gap. And what that looks like for healthcare providers is greater public awareness, where we do a comprehensive public awareness campaign to raise greater grassroots awareness and engagement. We provide training and education, a dynamic platform to educate healthcare providers so that when they do encounter it, they not only know how to respond, but they know how to also prevent it and bridge the gap between patients the NGOs, the social services, the law enforcement, and the healthcare providers. And then finally, additional safety and support resources that they need in order to do the things they need to do around assessment, reporting, and interventions. So why now? Why now? Because children and families and communities need hope. We need hope. I need hope. I'm going to be in this fight for a long time. So I am your patient. I need you on the front lines with me as an advocate, as a survivor, as a patient, as someone who trusts that it's going to be between us. Thank you.
Wow. Thank you, LY. Thank you so much, not just for your presentation, but for your patience and perseverance this morning. I know there were a lot of tech hurdles to jump through, but your message and the message of all the panelists this morning have been so crucial in this work as we move forward. And kind of ending on that, that note of hope, I want to pose to the panelists the question of, what gives each of you hope, either personally, professionally, or both, moving forward in this work? So, Sevonna, if you want to start.
Wow. I mean, I just want to say thank you to LY. And I think everybody in the audience knows that was worth waiting for, right? And just, you lifted up, and I think you left us with a charge and a mandate that landed with my heart, that it's urgent, right? Like what we do and what we're doing right now is urgent. And so I just want to express my gratitude. And when you ask the question, Nicolle, what gives me hope? I have to say very authentically and transparently, my ancestors, because I know that the burdens that they faced and the intersections of the burdens that they faced required a level of spiritual strength and radical communal care and mobilization that we all must answer to, right? And so sometimes that feels like it's so outside of how we define things currently, right? Like our services and our direct interventions and risk factors and protective factors and all of those things. But for me and for my community, our culture and our ancestors are a protective factor. And so I'll just leave that on the table, that authentically is what gives me hope and what ensures the thriving of my community. Thank you to each of you. This conversation needs multiple days.
Agreed.
I'm grateful for the time we had.
Thank you. Dr. Mosqueda.
Yeah, well, I want to express my gratitude as well. I learned so much from hearing from the other panel members, and I really am grateful and inspired. What gives me hope is that at the same time we can focus on the big picture and we can do the research and understand systems and try and poke through all of that stuff, we can help one person today, or maybe more than one. And what gives me hope is to know that there's just that one person where I can make a difference today, and I'm determined to do it, and everybody can do that. And I think sometimes we get so swept up in, it just feels overwhelming, it's too big, it's too this, it's too that. Find that one person who you can help, and that will spread.
Such a great point. I have a colleague who likes to say, it's 1 + 1 + 1 + 1, and we add up, right? We add up to make change. So thank you. LY, you brought up hope. What gives you hope moving forward?
Every morning, the two things I do every single morning, I meditate and I pray. I meditate and I pray, and I ask for what that hope would be for me for that day. And what gives me hope is my mother and my grandmother, who are both no longer with me. And I see promise, and I see them in promise. And even though she's 14 and got a little smart mouth now, she gives me hope. She really does. That I talked about the injury that I've sustained to my body as a victim. But more importantly, I think I'm more harm to my body has come in being in this fight, respectful fight around wanting to save the broader promise. And that gives me hope every single day, showing up at a conference like this and hearing how passionate we all are about wanting to do different.
Thank you. Thank you again. I want to echo from our attendees that this has been an amazing panel. You have all brought a lot of experience, education, information, and just, really validation to, I think, a lot of the things that the providers are experiencing in their day-to-day work, right? And just really the reason why we're all here. So thank you for instilling that hope in all of us. And again, reigniting that passion and that self-care, right? Because we can't do this work if we're not well as well. So thank you immensely to all of you. We are so grateful you're here today. And again, for your patience. It's been a roller coaster this morning, but you know what? We got through it and we were so happy to hear from all of you. We've grown from it. Thank you.
Thank you.
So I believe we are going back to Rebecca and we'll be moving into a break shortly. Rebecca, thank you.
Thank you, Nicole, and thank you to all of our great presenters. As Nicole said, we're going to take a 10-minute break and we'll see you all back here at 11 a.m.